so much for coming today. This is our third annual Carl Rinne Lewy Body Dementia Community Presentation. I will get into Dr. Boeve's introduction. Dr. Boeve is a consultant in the Department of Neurology and Center for Sleep Medicine at Mayo Clinic in Rochester, Minnesota. He serves as chair of the Division of Behavioral Neurology and is co-director of the clinical core of Mayo's Alzheimer's Disease Research Center. He joined the staff of Mayo Clinic in 1997 and holds the academic rank of Professor of Neurology at Mayo Clinic College of Medicine and Science. He received his medical degree from the University of Florida. He further trained at Mayo Clinic School of Graduate Medical Education, where he completed his internship in internal medicine, residency in neurology, and fellowships in both behavioral neurology and sleep medicine. His clinical and research interests include normal aging, mild cognitive impairment, Alzheimer's disease, as well as the non-Alzheimer's degenerative dementias, such as dementia with Lewy bodies, frontotemporal dementia, primary progressive aphasia, cortical basal degeneration, progressive supranuclear palsy, and posterior cortical atrophy. He's an expert on neurologically based sleep disorders, such as REM sleep behavior disorder, narcolepsy, and restless leg syndrome. Dr. Boeve also has an interest in prion disorders, neurogenetics, and autoimmune inflammatory encephalopathies. In addition to his clinical and research activities, in his free time, right? Dr. Boeve is active in education. He is the director of the Behavioral Neurology Fellowship Program and has teaching and examining privileges in clinical and translational science at Mayo Clinic Graduate School of Biomedical Sciences. He also provides mentorship to multiple fellows. And a fun fact, he's from Holland, Michigan, and is a Michigan fan, so go Blue. I'm honored to have you here today, Dr. Boeve. Please join me in welcoming.
Thanks, Rinne. Well, good afternoon. It's a real pleasure to be here. As Rinne was just saying, my roots are here. I was born in Beaumont Hospital, lived in Southfield for the first 4 years of my life, then moved across the state to Holland, where I spent many good years, and then moved to Florida, and then decided to come back to the north, and have been in Minnesota for the past 28 years. But I think it's important to tout the foresight of the Rinne family. I've been interested in Lewy body disease for most of my academic life, and I'm not aware of any other program anywhere in the country where a family had the foresight to build an educational empowerment program, and it's very impressive. And look at the attendance here today too, it's very impressive. So thanks to everybody for coming. What I'll try to accomplish some of this, I'm always struck by how sophisticated the audience is and ask really challenging questions. I hope some of this isn't overly simplistic, but this is what I'd like to review. First overview, then go over the clinical features, then the diagnostic criteria, which were recently updated, review the neuropsychological features, spend several minutes on imaging, which is quite important, spend a fair amount of time on management and treatment, and maybe we'll hold questions off till the end, but I'm sure there'll be questions about management and treatment. As everyone knows, this is a really complicated disorder and difficult to manage. Briefly talk about the neuropathologic features, and then spend a little bit more time on the research end. What are we finding out about genetics? What research avenues are being pursued right now and why? And the future really looks bright, and I hope you share that view by the end of the day today. So first, an overview. When I went through training over 20 years ago, Lewy body dementia, Lewy body disease really wasn't a known entity, and when the science started shedding light that this is a real disease, the thought was this was just a brain disease. But this is a systemic illness. It affects the brain, the spinal cord, and the nerves that go to several parts of our body. And as shown here, This is a bad schematic drawing, but these are brain structures. These are other structures in the brain and spinal cord, but there can be Lewy bodies in the retina, nerves that go to the heart, to the intestines, to the sex organs, to the bladder. And this explains the symptoms that a lot of people have. Drops in blood pressure, urinary dysfunction, erectile dysfunction, constipation. Some people require a pacemaker because of the involvement of the nerves to the heart. So a lot of these things that we didn't appreciate early on, and this is what a Lewy body looks like under the microscope. And these represent Lewy neurites, and we'll talk about this a little bit more. And the key protein that all of us should share our anger at is the alpha-synuclein protein. We'll talk a lot about that protein, and it's a normal protein. We all have it. It serves a normal function, but it misfolds and it becomes sticky, and when it sticks together, it forms this ball, and that's what Dr. Lewy first described under the microscope, and that's why his name is attached to it, so the Lewy body. And because of the complex array of the brain and peripheral nerves that this disease can affect, this explains the symptoms being so varied. So many people focus on the cognitive, so the forgetfulness and other cognitive aspects, but there are prominent neuropsychiatric features, hallucinations, delusions, apathy, anxiety, depression. There are many sleep issues. I have yet to meet a single person with Lewy body disease who didn't have at least one sleep disorder that has not been diagnosed and treated. And if you don't get good sleep, how do you expect to have a better day? And so an approach that's really important is to address all the sleep issues. It can really result in nice clinical improvement. The autonomic symptoms, constipation and the like that I just mentioned. Sensory things, some people have pain or numbness. Some have other types of sensory experiences. And the motor dysfunction relates to the Parkinson's related symptoms. And we'll spend a little bit more time about those specifically in the various approaches for management. One bit about nomenclature. This gets real complicated. The scientists can't agree on a lot of the terminology, but dementia with Lewy bodies and Parkinson's disease with dementia, those two disorders are viewed under the umbrella of Lewy body dementia. We sometimes interchange DLB and LBD, and I might do the same thing during the discussion today. But Lewy body disease is the underlying disease process that causes the syndromes of DLB and PDD. And some of this is some of the early features of evolving Lewy body disease, and we'll spend some time talking about that too. So what are the clinical features? I know many in this room are quite familiar with this, but Ian McKeith is a psychiatrist in the United Kingdom, and he's been studying this disorder throughout his career and really can be credited for a lot of what we know. And even 20 years ago, began to appreciate that Parkinsonism, visual hallucinations, fluctuations in cognition and or arousal are some of the core features of Lewy body dementia. Sometime later, it then became apparent that REM sleep behavior disorder, which I'll talk about more in a minute, is also very common. And actually, as we study this further, the presence of REM sleep behavior disorder is by far the best predictor of underlying Lewy body disease. And so this is part of the Lewy body disease spectrum. And for those of you who may not be familiar with REM sleep behavior disorder, we abbreviate this RBD, and I'm sure many in this room will acknowledge this parasomnia. So normally when we're in REM sleep, there's active paralysis. Our eyes move. That's what is called rapid eye movement sleep. And there's a few other muscles that will move, including our diaphragm, but otherwise we're actively paralyzed. RBD represents where that paralysis is lost, and people will vocalize or punch or kick or do more complex movements. Sometimes this is mild, sometimes it's quite dramatic, and injuries can happen to the patient or to the bed partner. This is not that difficult to diagnose and treat, and what we're learning is many people will have RBD in their 40s or 50s. Years later, then start exhibiting the more typical DLB features. So we think this is an early feature of evolving Lewy body disease, and we'll talk about that a little bit more a little bit later on the implications for treatment. One thing we've also appreciated is a lot of people with LBD are sleepy, and there's a lot of causes of sleepiness. We've done some work to look into this further, and not to get too bogged down in data, but in trying to understand the sleep issues in Lewy body disease as it compares to Alzheimer's disease and frontotemporal dementia, which are two of the other relatively common causes of dementia. As represented by this pink or purple bar here, DLB patients are a lot sleepier than those with Alzheimer's type dementia or frontotemporal dementia. And when you study this even more formally in sleep studies, those who have DLB fall asleep much more rapidly than those with Alzheimer's disease. Now, there's a lot of explanations for this. Some of it may be sleep apnea. Some may be leg jerks at night. Some may be restless leg syndrome. But in some people, it looks like it's actually part of the disease itself. Part of the circuitry in the brain, the same circuitry involved in narcolepsy, can be affected by Lewy bodies, and that may be at least part of the explanation of why some people are so sleepy. And I've seen some individuals that aren't asleep at all, some that can barely, they would be asleep in this room right now. They just cannot stay awake. Another aspect of the sleepiness is a phenomenon in sleep medicine that we call AFNARs, arousals for no apparent reason. So if you study a person as part of a sleep study, that person keeps awakening every half a minute or minute, not from sleep apnea, not from anything else that we can really put our finger on, but it's like somebody shaking that person awake every half a minute or a minute, and there's no wonder that the person's sleepy during the day. So these AFNARs, the ability to fall and stay asleep may be as affected as the ability to stay awake. And that's actually narcolepsy. So most people with DLB don't have overt narcolepsy, but a lot of their features resemble narcolepsy, and we'll talk about that more from a treatment perspective in a minute too. Now, many in this room have probably undergone neuropsychological testing. I'm sure that's one of the most favorite tests you've ever undergone. It's the stress test of thinking, but it's important from a diagnostic and from a management perspective. And the qualitative features of the cognitive impairment is quite different compared to Alzheimer's type dementia. Learning and memory may not be normal for the individual, but it's not as abnormal as executive function. So multitasking, complex problem solving, ability to avoid distractibility, those types of things. And then visual spatial functions, so orienting oneself in space, getting lost, those types of things. Those tend to be more common than severe memory impairment. And what we do in the office is have individuals try to draw some things. And we don't understand this very well, but in those with early Alzheimer's disease, these tests are not that difficult, but in early Lewy body disease, they're very difficult. So the ability to look at a two-dimensional drawing, cogitate about it, and then try to copy it, that circuitry is just affected and difficult. So you can see this is called the Necker cube, and these are some attempts to draw the Necker cube. These are some attempts to draw a clock. I'm sure, again, a lot of people have done this in an office setting. And this is one that we often use as part of neuropsychological testing. It's called the Ray-Osterreich complex figure, and you can see these were difficult for these individuals. Now, These are obviously examples that were pretty abnormal. It's more to make a point. So a lot of people in the office setting, they do better than these examples. But the point is, it's not that hard to do some things in the office that only take a couple minutes. And if a person really struggles on this, this is kind of a red flag for us to say there may be some Lewy body component to the cognitive picture. And this is how we can map out the performance on neuropsychological testing. I won't go through this in detail, but the main point here is the lower the bar, the more abnormal the performance, and these red bars are memory. So in Alzheimer's disease, that's what's really difficult for people with Alzheimer's disease. Contrast that with many people with Lewy body disease, a person may be forgetful in everyday life, but in a testing session, they rise to the occasion and they do pretty well on these tests. But they struggle more on attention, executive, and the visual spatial measures as reflected here, and those tend to be pretty normal in somebody with early Alzheimer's disease. So the value of neuropsychological testing. Now, imaging. This is helpful for diagnosis. It's also very important for research. As we plan for the big guns that are coming from a treatment perspective. If you compare MRI scans, so this is a person with DLB, this is a person with Alzheimer's type dementia, and what we're doing here is we're cutting the brain basically from ear to ear, taking the face and the front part of the brain out of the way, and if you focus on these structures right here, these are known as the hippocampi. Compare the size here, and basically, and I'm sure many of you have heard this, that despite a person having bothersome cognitive symptoms, their MRI scan looks pretty normal. That's the norm in DLB, and so the hippocampi here are normal, whereas in Alzheimer's disease, the hippocampi, the critical structures in the brain involved in making new memories, that shrinks. And that's why memory impairment is so pervasive in Alzheimer's disease. So when we do MRI scans, many groups around the country make sure that we get these coronal cuts, that's what these images are here, so we can really focus on the hippocampi. And you can actually quantitatively measure the size of the hippocampi, and several office practices now do that. Now, the standard of practice in evaluating somebody for suspected DLB is an MRI scan. And these other scans I'm going to talk about, you usually don't need to do. And I don't want to give the impression that a PET scan, DAT scan, and all these others should be done in everyone. That's not the message here. But when you do them, and in some people, their symptoms just don't make sense, and additional data is needed, and that's why sometimes these things will be ordered. The value of a PET scan and some of these other things can be quite high. So in Alzheimer's disease, blue and black is normal. These top images are as if you're looking at me from the side, the left side. These bottom images are as if we're cutting more towards the back part of the brain. Blue and black is normal, and so as you see in Alzheimer's disease, temporal and parietal, frontal, this part is spared, and the back part of the brain right here is also spared. That's typical Alzheimer's disease on a glucose PET scan. Contrast that with Lewy body disease, the back part of the brain is preferentially affected. And we don't understand this fully, why this is a typical PET scan, but that's also the back part of the brain that's involved with visual spatial functioning and some other cognitive aspects. So it actually does fit for a lot of people's symptoms. So if you do a glucose PET scan, this is what we're looking for. Now, I should say that some people have a normal PET scan. Despite having classic DLB features, PET scan can be normal. It can look like an Alzheimer's disease type PET scan. So this is not a perfect scan. But when you see it looking like this, there's very few other things that look like that for any of the neurologic disorders. So it can be helpful when it shows a classic picture like this. Another thing we look for is what's called the posterior cingulate island sign. So in DLB, you see this brighter white in this part of the brain. In Alzheimer's disease, it looks dark gray. And so it's just one more thing that we look at now that we've learned to appreciate this particular sign on a PET scan. DAT Scan Imaging. DAT Scan is used frequently in Europe and in Japan and a few other parts of the world because their federal medical system pays for it. Medicare and private insurance typically will not pay for DAT Scan, and it's pretty costly. It's about $3,000 to pay for it out of pocket, and obviously most people can't afford that. So we don't do this very often in the United States unless we do it for research purposes. And a lot of programs, including one of the programs here at the U of M, they do DAT Scan imaging as part of the research. And what we're looking for, it's measuring the dopamine system in the brain, and this is what a normal DAT scan looks like. This is called the double comma sign. In DLB, because the dopamine system is affected, it looks very different. So some people will call this a double period sign, but it's hard to see really any signal on this scan. And so you can see a DAT scan can be really helpful here. But again, it's just hard to get this covered for clinical purposes in the United States. So in research, we do a lot of these things. In clinical practice, we pretty routinely will do an MRI scan. The other things, it depends on the situation. But if you do these other scans, you can see that it's not that difficult when you do these scans to differentiate Alzheimer's disease from Lewy body disease. And that's usually the primary question, Alzheimer's versus Lewy body disease. Now let's spend a fair amount of time on management and treatment. And it's not really in any textbooks. We didn't learn this through our training. This has largely been taught to us by our patients and families, and this approach seems to work pretty well. And the key thing is to ask patients and family members, we need you to provide input. What's your priority list of things that are most bothersome? And this sounds cliche-ish, but everybody's different. And truly with Lewy body disease, it is quite different. So what's priority number one to work on, then number two, then number three? And the good thing is many of the treatments do help. And so priority one may get better and move down the priority list. The other ones move up the priority list, and then you start working on what was priority number two. And you have to keep doing that for weeks, months, years. But it's well worth the effort because some people really respond to a comprehensive approach towards management. That's the main point here. You can't just troubleshoot one thing or two things. You have to look at all aspects. So we've learned to separate things out. What are the cognitive issues, neuropsychiatric issues, motor, sleep, and autonomic? And what we mean by this, I'll talk about in a minute, but the implications then, based on the symptoms, we can derive with pretty high confidence what neurotransmitter system is off. Every neurotransmitter system that's ever been studied in Lewy body disease is affected. That's the bad thing. The good thing is this is where medications can be helpful. These medications are designed to boost the effects of these neurotransmitter systems. So acetylcholine is almost always abnormal in Lewy body disease. Hypocretin, which is involved with narcolepsy, has been implicated in LBD. Dopamine, for sure. Serotonin, which is more involved with sleep and mood and anxiety. And then there's other neurotransmitters, glutamate, glycine, and others that are probably involved with some of these sleep disorders. So to go through this in a bit more detail, cognition, so memory related symptoms largely relate to reduced acetylcholine. They may be in part due to these other neurochemical systems. And so these are the various cognitive issues that we ask questions about to get a sense, is this bothersome? And if so, is it a big bother or more of a nuisance? And if there's a lot of these symptoms present and they're quite bothersome, this is a high priority item to work on. And the way we approach this is true of any symptom, is education. The simple fact that you're here, you're seeking education to try to understand what is the mechanism for that symptom. Empowerment, so learning from each other and others. How do you manage this through non-drug means? And if medications are to be used, the logic here is that Aricept or donepezil, Exelon or rivastigmine, Razidine or galantamine. You know, life would be easier if it was just one name for each drug, but there's, of course, 2 or more names. But the standard of care is one of these. And the logic here is there's a reduction in acetylcholine. These medicines boost the level of acetylcholine in the brain. Sometimes there's a mild improvement. Some people, it's a dramatic improvement. And I've actually seen some individuals who are living in a skilled nursing care setting, and we've gone through a lot of treatments, including one of these acetylcholine-based treatments, and they really don't need to have the extra assistance in the skilled nursing care facility. So they move back home, and they can do a lot of things in the home setting. If anyone's not being treated with a cholinesterase inhibitor, that's what we call these, then it's very worthwhile to use one of these. You can't use 2 because that can slow down the heart or stop the heart from beating long enough that a person will pass out. So you can only use 1 at a time. Sometimes we'll use Sinemet or Mirapex. Sometimes we use some of these other wake-promoting medicines. I'll talk more about these in a minute. But the approach for the cognitive issues primarily are Aricept, Razidine, or Exelon. The neuropsychiatric issues like visual hallucinations, delusions, apathy, you know, some of these names, they're not very kind words. And it'd be nice to have names of symptoms that are not as negative sounding, but these are the medical terms that are often used. But hallucinations and delusions are due largely from dysregulation of dopamine. And so the approach, one, is you don't use that drug. If I can drive home any point today, no Haldol. Haldol should never, ever, ever be used. It still is, a lot, and it causes bad problems. But Haldol and other cousins of Haldol that have been around for decades, we really should not be using. But if any of these symptoms are present, then one, what are the non-drug approaches to understanding why they're apparent? One of the things about visual hallucinations, we think part of the mechanism is that in REM sleep behavior disorder, again, this is the sleep disorder where people seem to act out dreams. So aspects of wakefulness are invading into REM sleep. What about the opposite? Aspects of REM sleep, dreams, invading into wakefulness. That is the substrate for visual hallucinations, or at least has been hypothesized to be the substrate for hallucinations. And if you think about that, it kind of makes sense. So in those who have hallucinations, they are absolutely real phenomena. There's no sense arguing about it. Those are real experiences for that individual. And so to try to understand that these are real experiences, they're not what other people are seeing, and there's a variety of ways to try to just talk through this so that it's not frightening and doesn't consume a person's thoughts. But there's, you don't always need to treat hallucinations with any medications. But when they are pervasive and leading to a person to really think about it and be bothered by them, you have to do something. And so sometimes these same medicines that we use for cognition will also greatly reduce hallucinations, Aricept, Razidine, Exelon. Sometimes we use other agents, even melatonin. Why melatonin could help, we don't really understand, but some people, melatonin at night and hallucinations during the day will go down or will be gone. And I've seen this many, many times. We often are in a sticky situation, though, where hallucinations are very bothersome. We feel the need to do something. Patients are really bothered by it. The family's really bothered by it. And this is where medications like Seroquel, Zyprexa, Risperdal, Abilify, and this is a very controversial area. And maybe after we go through this talk, we can talk a little bit more about, these are called the atypical neuroleptics. Most clinicians feel that they do have a role and they can be quite helpful, but there are some downsides. And we have to talk through the pros and cons with each situation. But those are used fairly commonly with variable success. Sometimes the wake-promoting agents can help hallucinations. So this is where our knowledge from narcolepsy again comes into play. In those with narcolepsy, they have hallucinations. It's the dream imagery invading into wakefulness. And by using a wake-promoting agent like Ritalin or other medicines that promote wakefulness, it will suppress hallucinations. Now, this is also controversial because most clinicians are trained if you use something like that class of medicines, it's going to make hallucinations worse. And a lot of clinicians are not trained to use that class of medicines very much, so they're just uncomfortable using them. So it is controversial also, but some will have a very nice improvement in hallucinations by improving alertness, suppressing the REM sleep intrusions into wakefulness, and therefore hallucinations are less frequent or better. Motor issues, this is primarily the Parkinson's-related symptoms, so tremor, slowness of movement, rigidity, shuffling gait, stooped posture. There are the Big and Loud program. There's a variety of non-medication approaches that can be quite helpful for those who have significant Parkinsonism. Working with a physical therapist and occupational therapist, I would highly encourage that if you aren't working with one or more therapists, to identify one, whether it's a physical therapist, occupational therapist, a trainer at the Y, a trainer at another type of health club. You have to find somebody that thinks a little bit outside of the box, to be honest, but who wants to be aggressive with the physical activity. If you look at the published research, those people who are physically active, their rate of change is slower than in those who aren't physically active. Very good studies now, 6 of them now published, and this is, includes in the setting of Parkinson's disease. So physical activity, it doesn't have to be running to the point you're sweating. Physical activity, a good walk on a regular basis. If there's a risk for falls, you have to find other ways to get that physical activity in, but to really drive home the importance of physical activity. If Parkinsonism is still pretty severe, then we consider medications. Sinemet is the mainstay. Mirapex, Requip, there's a patch called the Nupro patch we use with some frequency. These are not easy medications to use. They're kind of a pain. Sinemet usually works, but it only lasts 3 or 4 hours. You have to take it on an empty stomach for it to work best. It's just a pain to use, but it does work for a lot of individuals. These are longer acting, but hallucinations often happen. So this is not an easy thing to treat with medications. I'm sure there's people in this room that will attest to that. Sleep issues, this includes treatment of sleep apnea. I'm a sleep clinician as well as a behavioral neurologist, and I hear so often and so frustratingly that a person with a cognitive problem, why even pursue sleep apnea? Because they won't tolerate CPAP. That's just not the way to think about this. A lot of people will tolerate CPAP if they have obstructive sleep apnea. And you think that the neurologically normal population, the CPAP compliance rate is about 50%. So half of people who are in their 30s or 40s have no neurologic symptoms. They just can't tolerate CPAP. And for those who aren't familiar with CPAP, that's the breathing machine. So it's a machine with a tube and a mask that goes over the nose, and instead of the every night, it blows the throat open. No, I don't snore. Wrong. But the CPAP will blow the throat open, and it will keep the snoring from happening, and it will eliminate obstructive sleep apnea. So for those who can tolerate using it on a night, on a regular night, they sleep better, and they're less sleepy during the day, and their cognition is better during the day. So if anyone in this room is a loud snorer, has pauses or gasps in their sleep, has a type of setting, and they're sleepy, very likely that person has obstructive sleep apnea, and it's worth having a sleep study and at least trying the CPAP. This is just some quick data. We did a small study in patients with DLB a few years ago using a medicine known as Nuvigil. I'm not trying to promote a single medicine. This is more of a proof of concept. But the point here is we measured this formally in 20 individuals with DLB who were sleepy, which is a lot of people with DLB. Every one of these green lines represents the before and after effects with this medicine. So as this goes up, that's improvement. You can see some of these lines are pretty steep. Some of these are a little bit more flat. And in this box, the opposite. If the line goes down, that's improvement. It's just the way these scales are done. As you can see, out of these 20 individuals, only 2 didn't improve with this medicine. And we saw a couple patients really nice improvement. So the point here is if sleepiness is present, you're already treating obstructive sleep apnea, then is it worth at least considering a wake-promoting agent, and it's at least worth a discussion. The way we treat REM sleep behavior disorder, this is very common in DLB, is if it's mild, we just do things around the bedroom to protect the individual and the spouse. And so put a mattress on the floor, move sharp objects away from the bed. You don't necessarily have to use any medicine or over-the-counter agent. But if the dreams have a nightmare quality and are unpleasant and injuries have occurred or might occur, then melatonin is a standard. And this is just over-the-counter melatonin, 3 or 6 milligrams per night. It works about half the time, so not near everybody benefits, but it's cheap, it's easy, there's really no side effects, and it's worth using. So that's our standard. A better medicine for treating REM sleep behavior disorder, but it has potentially a lot more side effects, is a medicine called clonazepam or Klonopin. It's a Valium-like medicine, but it's unique in its properties. It works very well for RBD. Most people at low doses, they don't have any side effects, but this is another area that there's a lot of controversy. A lot of primary care physicians, family physicians, as well as neurologists, they're just not keen to use clonazepam, and all of us understand why, but in many individuals, if RBD is really severe, you want to protect the individual from having an injury. So clonazepam does have a role. And then finally with the autonomic symptoms. So this is again dropping of the blood pressure and fainting or near fainting episodes or severe constipation, erectile dysfunction, things like that. If a person has orthostatic hypotension, what that means is when you stand up, you get lightheaded and you feel like you're going to faint or you do faint. And that's relatively common, and it is treatable. You can use abdominal binders, or people hate these, but thigh-high compression garments. They're a pain to put on and they're hot, but they do help to some extent. Adding salt to the diet. This is one of the few times where we recommend salt as opposed to low salt diets. The purpose here is to increase the water content of the bloodstream. So if there is a drop in blood pressure, it's less of a drop. So there's a variety of ways to manage that drop in blood pressure. There are also some prescription medicines that also have some pros and cons, but that usually isn't too difficult to manage. Impotence or erectile dysfunction, it can be hard to manage, and many people will use Viagra, Cialis, or Levitra, and with variable success. Urinary incontinence, this gets tricky. There are medicines like Detrol or oxybutynin that basically counteract the effects of Aricept. And a lot of the urologists don't know this, so they're trying to treat it, but what works around the bladder works against you from the brain perspective. So there are some other agents. They're pretty expensive. Gelneek, Sanctura, now even Mebetric. If you've seen the commercial of the purple bladder chasing a lady around, that's the advertising part. So that medicine actually does work okay, but it's super expensive. So there are some approaches, but there's, again, pros and cons. And then Miralax is our favorite for managing constipation. It usually works pretty well. Add bulk and fiber to the diet, drink a lot of fluids, but Miralax is pretty easy to use. And it's not technically a drug because it's a powder. You have it with water or a liquid. It stays in your GI system, so it doesn't get in your bloodstream, but it acts by just pulling in more water, so constipation is less of an issue. So to summarize, this is where we are, and this is really complicated, but this is the nature of managing symptoms in DLB, and this is why so many patients, families, and clinicians feel stuck. I won't go through all of this, but let's just take this column here. So we can use the atypical neuroleptics to try to improve hallucinations and delusions. The green box represents that they often help. The downside is it can make cognition a little bit worse, shown by yellow. Parkinsonism can get worse. If they're sleepy, they can get a lot sleepier, represented by red. And if they have this drop in blood pressure when they stand up, it can get a lot worse too. And almost every one of these classes of medicines, there's the pros, but there's also the cons, not only in the symptoms, but also, oh, I didn't include it, but also, excuse me, some of them can affect your blood count, so you have to have blood tests every so often. Some can affect the electrocardiogram, so you have to have an EKG every so often. So this is not easy to manage, and frankly, it is a trial and error type of approach, but find a clinician who's dedicated to try the trial and error approach using that priority system. So if you as patients and families give the priority system to the clinician you work with, work on priority number one, hopefully you'll see some improvement, and if that does happen, that'll go down on the list, other things will raise up, and then work on priority number two that has just become priority number one. And you just keep doing that, and you keep managing every aspect you can while getting some physical exercise and treating the sleep issues as best as possible too. So this takes weeks, months, a lot of office visits. We all get that, but it's worth the effort. A couple words on the neuropathology. I know this isn't a fun thing to think about or talk about, but this is a critical aspect of research in brain donation, as it's sometimes called. It's one of the greatest gifts to science. And for those who feel comfortable doing this, then to arrange for autopsy. I have Alzheimer's disease on both sides of my family. I'm planning to do this. My advance directive already says this. So there's a lot of reasons to plan ahead. And the reason this is valuable are severalfold. One is we can see the Lewy bodies in the brain now very easily with these new staining techniques. So it helps to, frankly, provide closure, this was the cause of a person's symptoms. Sometimes we're surprised. We find out that it's a different disorder. And again, from personal experience, my grandmother on my mother's side had pretty typical Lewy body features. And she passed away, an autopsy was done, and it was Alzheimer's disease. So that does happen. And it's not to say the clinicians were wrong necessarily, this is the nature of the beast, and that's why we're doing the research. Predicting the pathology in individuals, it's a very imperfect science, and we need to get better, and we can't get better if we don't know what's the ultimate cause. So, plus the tissue, some of the most critical scientific things can only be done on tissue. And so an added value of brain donations. So again, our anger is on this alpha-synuclein protein, and we'll talk about what we think happens to that protein in a minute or so. A few things on genetics. This is a hard thing to study. This will change over the next year. But we hear very frequently that a person with DLB has a relative with dementia, Parkinsonism, or both. And if you actually look for the known genes and test those genes, 99.9% of people will have no mutation found. But the family history suggests there's something genetic potentially going on. But the main point here is it's extremely rare to have a single mutation causing a person's illness. But that doesn't mean there aren't genes involved. So this is the way we're thinking about the genetics of Lewy body disease. I should also say in Alzheimer's disease, we think genes have a much stronger role. Frontotemporal dementia, a much more strong role. In Lewy body disease, we suspect there are many genes involved, maybe 10 or 20, but they all affect risk. And a lot of this is just luck, to be honest. So if you get 10 genes from mom, 10 genes from dad, and it just happens that much more of the protective variants are passed on as opposed to the risky variants, that person probably won't develop LBD. If it's flipped, then that person is more likely to develop it. And like most things in medicine, there are likely some environmental factors that contributed to it too. So you have to be exposed to pesticides, certain viruses, some other environmental things that we understand even less well in the appropriate genetic setting that will affect risk. That's what we think is happening as to the cause. So these are some of the genes that we know about. This is the alpha-synuclein gene, very, very rare. And so in the population, it's really rare. But if you have a mutation in this gene, you will develop an illness, Parkinson's or DLB. Other genes like ApoE or GBA, as it's abbreviated, these are more common, but they don't have much of an effect on risk. What we really need is a panel of all genetic markers that affect risk, up or down, and we're going to find this out over the next few years. And if you haven't heard about whole genome sequencing, this is really important for medicine in general. So the technology is now available, and this can be done for as little as $500. A blood sample, do a whole genome sequencing, you map out all of your DNA variants, this is millions of DNA variants, compare it to the normal population, and then learn what variants are more common in people with the disease, not common in people who don't have a disease. Those genes or variants probably are involved with the pathogenesis. We just haven't had the technology until recently. Now the cost is down. The hard part now is we don't have enough, and you need tens of thousands of people who are neurologically normal, because if any one of us did whole genome sequencing, we would have hundreds of variants that look abnormal, but we don't know what they mean yet. So we need the normals to determine what's abnormal. This has actually been going on in DLB, and the results of a major study will be provided to the scientific community in January or February. So this will be billions of data points available to scientists worldwide, and as more normal variants get published or available, we'll be able to map out all the genetic variants that are involved in Lewy body disease, high blood pressure, cancer, you name the medical disorder, this will begin to be worked out. So this is really the last frontier of medicine. We're going to learn a lot. There's going to be a lot of ethical issues too, but we'll learn the variants involved with Lewy body disease, and then as we learn these variants, we'll know where in the pathway of causing alpha-synuclein dysfunction or other protein dysfunction, where can we intervene with the therapy. And so it's a very exciting time that we're going to get a lot more data and we'll understand this so much better. And the big news, you'll probably see this in the news too, January, February. This is all being done at the National Institutes of Health. Our tax dollars are paying for this. But it'll take some time for the normals to be accumulated and the computer capabilities to crunch the numbers on all this data. They're talking pentaterabytes or whatever the word is for a lot of data points. But it's very exciting scientifically. So this is what's being studied right now. We're going to be able to map out these genes in the future. One of the things that we have been finding, and we've been involved with this research over the past year, is some people will have variants where their alpha-synuclein is ramped up. They're making about 10 or 20% more of that protein than the normal population. It's not a blood test you can do commercially yet, but think of it like this. Why do we have our cholesterol checked? If our LDL is high, and we've tried diet and exercise and we just can't get it down, we'll use a statin medicine, and by doing so, we reduce our risk for heart disease and stroke. This may be the same concept. If our alpha-synuclein protein is just being overproduced and there are agents that will reduce it, then we may have a prevention or a treatment for Lewy body disease, Parkinson's disease, and the like. Same thing for Alzheimer's disease and other protein dysfunction disorders. So this is going to be a very exciting time over the next 2 to 3 years as we learn what really is at the root of LBD. And the obvious hope is treatments will be available to intervene. But in order to intervene, we have to understand this better. And this is what frustrates the scientists enormously is almost everybody with DLB, it's not a single protein problem. So Lewy bodies, the alpha-synuclein protein is present in everybody by definition with Lewy body disease, but 80% of people will have some degree of Alzheimer's changes in the brain too. It may not be overt Alzheimer's disease, but Alzheimer's changes, and that's amyloid and tau. So most people, especially over 75 or 80 years old, it's not a single disorder. It's alpha-synuclein, amyloid, and tau. And we don't have a treatment for any of those yet. Now, we will, but just treating the alpha-synuclein probably will make a big difference. But will it be as impactful as if we have an amyloid, a tau, and an alpha-synuclein therapy? This is what the pharmaceutical companies are thinking about. They're looking at multi-protein therapies to absolutely optimize the brain. But we first have to understand who has pure Lewy body disease, who has mixed Lewy body with other features, and this is why so much biomarker research is being done. And for those of you who have been involved with research, thank you. It's absolutely critical to learn more about these aspects of Lewy body disease. So we need these biomarkers for all three and other proteins. And how do you do this is providing blood samples, undergoing spinal fluid exams if you're comfortable doing that. The CSF has much more higher concentrated proteins than you can pick up in the blood, and that's why the CSF exams are done. There's data now that even a skin biopsy or a salivary gland biopsy, you can see Lewy bodies on these biopsies. It's not perfected yet, but we may be doing skin biopsies or salivary gland biopsies as part of the diagnosis over the next 5 years. And then imaging, and I'll show more images over the next few slides. We've been very active in DAT Scan Imaging at our center. These are some examples of normal DAT scans where you see the double commas here, and these are examples of more abnormal. And all of these individuals had a DAT scan as well as MRI and other PET scans. We followed them for several years. They granted permission for autopsy, so we know the underlying cause. And using the DAT scan imaging, the main point here is if we just base on clinical diagnosis alone, we're so-so in terms of sensitivity, even worse with specificity. Just using the DAT scan, the percentages are higher, especially for specificity. Like every test in medicine, nothing's 100%, but just this test is better than the clinical diagnosis alone, at least based on these data. So DAT scan imaging does provide important scientific information. This is some work from our center showing amyloid uptake. So these gray structures are like models. The red is where the amyloid is present, and you can see amyloid by using another type of PET scan. This has completely revolutionized aging and Alzheimer's disease research, the ability to actually take a picture of one of the key proteins in the brain, amyloid PET. And so in DLB, then a lot of people have evidence of amyloid in the brain, and you can see this by this image. And if you do a number of these studies, you increase the likelihood of predicting who has what underlying their symptoms. So looking just at the MRI and the hippocampi showing some atrophy, so reduced in size, that's typical of Alzheimer's disease. They're normal in DLB. PET scan shows a different type of picture. The amyloid PET scan shows a different type of picture. So if you map this out on three-dimensional types of graphs, you can predict with a pretty high degree of precision underlying AD versus underlying LBD. This is another fancy type of MRI scan that can be done as part of a standard MRI scan. It's a lot cheaper than a regular PET scan. And then this is the latest type of PET scan. This is a tau PET scan, and green is normal. These are two individuals with DLB. Tau is a protein that is part of the tangles that is inherent in Alzheimer's disease. Again, about 80% of DLB patients have some degree of Alzheimer's changes, whether it's overt Alzheimer's disease pathology or not. And you can see this individual, by the amount of red, there's a fair amount of tau in the brain. This person is more, it's not as severe in terms of density, it's more orange. But what we're finding in DLB, tau is present, but it's in a different part of the brain than what you see in typical Alzheimer's disease. This may be a clue as to why the symptoms are different in DLB compared to Alzheimer's disease. But this has only been around for a few years, so we're still early in our understanding. And the U of M has a very active DLB imaging program for research, looking at tau PET, amyloid PET, and these other biomarkers. So it's a valuable source of research. So these are the various things that are being done across the country as well as in other countries. You see this long list. Many of them we've already talked about. And again, for those of you who are participating in research, thank you. If you're interested in research, please talk with the team from the MADC, and there's other written information that you can read about as well. Therapeutic trials. I'm going to just skip this part. These are the only, unfortunately, clinical trials going on right now in DLB. One is using a drug E2027. My battery just went defunct. The second one is a medicine used called pimavanserin. The brand name is called Nuplazid. It's a real expensive medication, but it can help hallucinations in the setting of Parkinson's disease with hallucinations. And there's the third one is a cousin of pimavanserin called nilotanserin, and that one is near the end of that study. There's one company that, as of 3 years ago, Axivant Pharmaceuticals, that had any interest in Lewy body disease. That was really the first time any company had an active interest in DLB. Unfortunately, the evidence of the trials have been negative so far. In the nilotanserin, we're still waiting on the results. They tried vigorously, and it's not their fault. It's just some of these medications just didn't hit the bar that the FDA requires for it to be considered worthy of being on the U.S. market. But what's happened, and this isn't, you don't see this in the news or on the internet, but there are now over 15 companies that have approached the Lewy Body Dementia Association Research Centers of Excellence program. University of Michigan is one of the research centers of excellence, and there will be many clinical trials that will be starting over the next few years. It's actually a bit of a daunting scope, because there's so much interest now by the pharmaceutical industry, we're going to have to be selective. So it's going to be going from nothing or very little to having an overabundance, and we're going to have to be more selective in what are the heavy hitters in terms of treatment. So, but we'll take it. If we have these therapeutic approaches, that's great news. And then final set of things, some research priorities. It's important to be aware of what's happened over the last 3 years at the federal level. The NAPA, National Alzheimer's Plan Act, Alzheimer's disease-related disorders, so NAPA ADRD. This was set up under the Obama administration. It's being maintained through the Trump administration. And the point here is Alzheimer's disease, Lewy body dementia, frontotemporal dementia, and vascular dementia all have been raised at the federal level of worthy of having a plan. How are we going to attack these? And this has led to an over doubling of the amount of funding for these disorders over the past 3 years. I don't know if you've seen this much in the news. This is really important. The more money we throw at this, the quicker we're going to have therapies. It's a money issue. And to see Congress, this is bipartisan support of a dramatic increase in funding in Lewy body disease and other disorders. And this is the plan that was set out as of a couple years ago. This is going to be updated for Lewy body disease in March. And again, this is partly why the pharmaceutical industry has become so interested. They see the profit potential, but also the scientific potential. We understand this better, and there's a real likelihood we'll have therapies. So there's a number of programs going on around the country. The Alzheimer's Disease Center program, one of them again is here at the University of Michigan. There's a Parkinson's disease biomarker program focused on DLB. There's only 5 of these nationwide. Again, one of them is here at the U of M. The U of M is one of the Lewy Body Dementia Association Research Centers of Excellence in the RCOE program. We have another study, which I'll show you in a minute, that's just getting off the ground. It's called the NAPS study, North American Prodromal Synucleinopathy. That's why we're calling it NAPS. And this is focused on REM sleep behavior disorder. I'll touch on this in just a minute. And there's many other programs in other countries. So this is not just a US attack, but many countries. So these are the Alzheimer's centers around the country, and again, my laser barely works, but Ann Arbor, several others around the country, about 30. These are the research centers of excellence spread across the country, and the mission here is education of patients and families and building infrastructure for treatment. There are some other novel things we're doing in DLB. I won't spend much time on this. This is the NAPS consortium, and this is starting off small, like a lot of scientific efforts do. There's 2 sites in Minnesota, 1 in Montreal, and you can see some of the other sites. This is focusing on people with REM sleep behavior disorder. Almost everybody with RBD, if they live long enough, will either develop dementia with Lewy bodies or Parkinson's disease. Not everybody, but most of them. We need to understand the natural history so we can intervene. And we think, where is prevention the most likely to happen? If we can find people in their 40s, 50s, 60s who have REM sleep behavior disorder, no other symptoms, if we can intervene with a therapy that attacks alpha-synuclein or one of the other therapies, we could delay the onset or perhaps prevent Parkinson's disease and Lewy body dementia altogether. This is a realistic possibility. We have a long ways to get there, but we know what to do, and the NAPS program is the first one. One thing about the alpha-synuclein protein, this question comes up a lot, is what does it do, and what happens to cause the trouble as part of DLB? The alpha-synuclein protein, this is a really bad drawing of mine, bad drawing of a cell body, the axon, and then the synapse over here. These green structures are supposed to represent the alpha-synuclein protein. All of us have normal alpha-synuclein as part of the synaptic proteins. Something causes the proteins to change shape and move up the axon, move into the cell body, and they change shape, they get sticky, and as they stick together, they form these clumps, and that's what, again, we call a Lewy body. So it's this process of moving up into the cell, and we think it's not the Lewy body per se that's doing the damage, but this process is stressing the cell and affecting the normal movement of nutrients and waste across the cell. And so remember, the MRI scans in people with DLB, it's usually pretty normal. So that tells us that not many nerve cells have died. If they died, we'd see it as part of atrophy. And in Alzheimer's disease, that's what we see. In DLB, it's not the case. So it's making cells sick, but not killing many of the cells. So one more reason that we're hopeful that therapies will have more promise in LBD. So again, to emphasize the future prospects, if REM sleep behavior disorder starts many years before mild cognitive impairment and then DLB, and we have a treatment that we can start, I wouldn't say worst case scenario, but one thing is it could slow down the rate of change, but it wouldn't affect the age of onset. What we really want to do, though, is we want to push it back or prevent development of DLB and PD altogether. And again, the scientific community feels that this is possible. We know what to do, but we have to study people longitudinally to understand the evolution of what happens so that while we work with these different agents that can delay. One last point, the next international conference on Lewy body dementia will happen in late June. Everyone here is welcome to attend. There'll be more in on the internet and from the LBDA over the next few months. It'll be, again, Las Vegas in June. Doesn't sound that appealing. It'll be 120 degrees, but we'll be inside in AC, so that's fine. And there will be a strong patient and caregiver component, probably 2 days. For anyone who was at the last meeting of this type in Fort Lauderdale, very positive feedback by those who attended. And they're really trying to keep the financial impact of this as low as possible, so as many people can attend. So I'll stop there. Thank a number of people that I work with, as well as many people abroad and the National Institutes of Health, as well as some very kind families. The Mangorian family has supported us for many years. The Little family is supporting us, as well as the Lewy Body Dementia Association. So thank you very much for your attention, and I guess I went way over. Sorry, but happy to take questions. Thanks again. Maybe, if anyone has questions, if you can yell, or this won't go very far, and I'll just repeat the question. Yes,
This is all on research you're telling us. What do I do now with my husband who was just diagnosed in June?
So the question is, a lot of the discussion was on
He's in a
research.
facility.
So what to do now in a person with DLB, because of the unique nature of every individual, is to find a clinician who's knowledgeable in DLB and work with that person.
He's on certain medications, but none of what you suggested.
Okay. So again, identifying a DLB expert, and there's several here at the U of M, and maybe Rinne and others can help direct you to the right clinician.
I think it's actually, why research now when he's already diagnosed and he's already in a facility? What do I do to control him in the facility? You didn't answer a lot of my questions. That's what I came for. I
Okay.
didn't get any answers to that. I got research, but it's too late for research. Everything you said has.
Well, all I can say is to try to work with a clinician who's knowledgeable in DLB. I've seen individuals in skilled nursing care facilities with aggressive treatment who have done very well and have been able to leave a skilled nursing care facility. I don't know if that's possible, but until you hook up with a clinician who knows what they're doing,
I don't think it's possible. Too long. It was 4 years before I put him in the center.
oh, I've been caring for people with LBD for 15 years. So some people, it's a very slow process, or it's fast, and with treatment, you see a nice improvement.
It's difficult for myself to deal with.
Oh, I'm
Many
sorry.
issues. So I didn't get many answers.
It is? Uh-huh.
Yeah, okay. So you talked about that one thing that is needed for one of the research studies is a lot more normal points, scans. What is the type of person that you want to get that normal scan? Is it a certain age, a certain what?
Yeah. So how to get the data on normal individuals to help in finding the abnormal genes. And this is dependent on the community that you live in. So some centers have a normal aging study. There aren't many of them across the country, but they have thousands of people. We have about 3,000 in Little Old Rochester, so we're trying to do this now. So if so maybe Rinne can expand on that. But you know, a lot of people, especially if you have a personal connection with someone with this illness, you know, it adds our motivation to be involved with research, and it's really helpful. But the reason for doing some of the biomarker research in the scans, that way you can tell that this person, there is no evidence of neurologic problem. That's important. So if you find anything in the genetic profile, then it must, and an abnormality is found in someone with an illness, and for example, you do not have that, that's meaningful. So in someone who might have a lot of amyloid in the brain, then it'll be harder to interpret that data. But the main point is a normal aging study. Does that make sense?
Clinical question.
Mm-hmm.
My husband is in end stages of Lewy body, and he is extremely aggressive and combative, constantly touching. He will grab onto you and almost break your fingers, and he can't let go. And he does a lot of jerking, more things
Very good question. So she was describing her loved one who is having a real tough time and basically acting out when intervened. Remember, with anyone where, if you want to use the term acting out, they're trying to communicate. It's absolutely critical, and not to fault somebody for being aggressive or acting out. They're trying to communicate, but they don't have the normal way to communicate. So something's amiss, and the task is for the team to figure out what that is as best as possible. So if the person is in pain, hungry, poor vision, poor sight, it's really difficult to understand this well, but that's the approach, is what is this person trying to communicate? And morphine, perhaps he is in pain, and that's helping.
It happens no matter if you go near, like if you touch him, he's just like this. And it's like sleeping. Oh, is what I think he's saying, but we can't feed him anymore because he can't swallow. He has been able to for boyfriend, and he's just been living for 10 months. And initially he could understand what he's saying, now he cannot understand. So it's just progressed, but this strength that he has in his hands is just astounding. It's like, and so what is that all about? Is that just something in his brain that is not, I mean, it's like he could break his fingers just from holding.
To the extent we can apply the imaging study, so she's asking why there's so much strength despite other things not being near normal. If you may recall back to the imaging studies, the motor system in the brain tends not to be, the motor cortex, the ability to grab, move the limbs, they may be slower because of the dopamine dysfunction, but the ability to walk or grab, that's preserved. And if other things are being interpreted, or the person is trying to communicate, they'll use whatever means they can to communicate, and because that's normal, that's why it's more of a physical explanation. So this, I don't mean to make this simple, it's really hard to get to the bottom. Why is the person acting out, if I can use that term?
He's in hospice now, and we're just treating his symptoms.
Yeah.
He's on Seroquel and morphine and just to.
Yeah. Good questions. Yes, ma'am.
You said that there's usually an environmental trigger with the LDD. My husband was diagnosed with Lewy body disease caused by Agent Orange. Is that are there studies that are looking at what those environmental factors are?
Yeah, so the question is, what are the potential environmental factors? This is being studied. It's harder to study because, for example, Agent Orange, one, it's amazing the federal government admitted this, that it may be a factor for Parkinson's and Lewy body disease. You know, it took years for them to even be in an admission role, but the data was pretty compelling. The harder aspect, so for example, the environmental factors are largely based on epidemiologic research, which means that if you look at a population and a disease process is higher in certain groups of people than in other groups, something about that group may be unique and that affects risk. So farmers have been found to be more likely to develop Parkinson's disease and to some extent Lewy body disease. A study we did in Olmsted County, which is where Rochester is, the profession that's most likely to get Lewy body disease based on autopsy data is a physician, and which is scary, but it gets you wondering, could it be being around a lot of sick people, are viruses coming into the nose or through the gut, or are there anesthetic agents that surgeons are exposed to in the OR? You know, all we can do is hypothesize at this point, but try to study it more. But some of the evidence for pesticide is pretty compelling. So, I'm sorry?
Don't use Roundup.
Don't use Roundup. Even rotenone. If you look at some of the garden pesticides, look at the label. If it has rotenone in it, that's a concern. And so even to wear gloves if you're going to use that for gardening. So, but these pesticides, because when, for example, if you study the brain tissue after an exposure, even Agent Orange 20, 30 years ago, you can't detect the chemical in the brain. And if you can't detect it, it's hard to prove. There's enough evidence with Agent Orange, people felt confident there is a causation. But in a lot of other, even the pesticides, you can't measure those pesticides in the body or the brain years later. So that's one of the reasons it's been so hard to study. And I shouldn't say this, but smoking may reduce risk. Caffeine may reduce risk in Lewy body disease. So now the thought with smoking is people die from lung cancer prior to, so that's one explanation. But caffeine's interesting. Having at least 1 cup of coffee per day may have a protective effect. So, and again, this is all based on epidemiologic research. Yes, sir.
Have there been studies regarding ethnic grouping as it relates to Lewy body dementia?
Another good question. So any ethnic grouping, Lewy body disease has been found in every ethnic and racial group that has been studied. There are some differences in the frequency or prevalence, but African Americans, Asian populations, European populations, clearly it's present in all of them. But it does seem, and the data are somewhat limited, that the frequency may be lower in African Americans compared to Asian and European descent. But we don't know of any ethnic or racial population that is protected. Yes, ma'am.
I apologize because I missed the first 20 minutes. I'm not sure if you covered any of this or if it's appropriate. But so when you're looking at getting a diagnosis in the first place, for instance, my father was diagnosed in 2012 to 14 with white matter in his brain. And so my mother and father are treated by a lung specialist as their main doctor outside of the area that they come for medical help, and they don't ask a lot of questions. So the thing is they're just being treated for Parkinson's, vertigo, memory, and the white matter. And so I asked my mom finally recently, she came out and said, well, maybe kind of Alzheimer's. So they don't really have a clear basis, and I don't know that they're going to get it from the doctor you see. He's a probably great doctor. But as a family, and we're all trying to start pitching in on how to help, it's like, where do you go in the sense of a family starting out to get your questions?
Yeah.
You know, I'm researching and reading, and it sounds like my dad is a prime Lewy body, but I'm not the dad.
Yeah. One thing that many clinicians will say is the patient and family is almost always right. And if you're strongly suspicious of Lewy body disease, it's worth pursuing. Not only to get a more fixed diagnosis, but as we went over, there are a lot of treatment options to consider. And so maybe trying to use some of the resources here to identify a good clinician. So, yeah. You're welcome. Yes, ma'am.
How can you tell where a patient is in the progression of the disease?
How can you tell where a person is in the progression of the disease? This is very difficult. In Alzheimer's disease, you can tell by severity of symptoms. The MRI scan provides a lot of valuable information. If there's not much atrophy, probably in the early stages. If there's a lot of atrophy, later stages. The MRI doesn't help as much in Lewy body, again, because it looks pretty normal. And so a lot of this is based on clinical features. And some people from onset to passing away, it's 2 years. Some people, 20 years, really slow, or even longer. Most people, it's in the 7 to 9 year range from onset of symptoms until passing away. And the symptoms fluctuate. and some of the symptoms respond to therapy. So I wish I could give a better answer. We're asked this essentially daily. And if the MRI shows a lot of atrophy, that suggests coexisting Alzheimer's disease, and you can stage things a little bit easier, but in the absence of that, it's really hard to predict. And this, we were talking about this earlier today, this adds to the complexity of when do you involve palliative care specialists or hospice. And in the setting of cancer, it's a little bit easier to predict. And in degenerative illnesses, it's a lot more difficult. I have a patient who I've been involved with who has been on hospice for 5 years. And I really thought that his longevity was very guarded. But every 6 months, I keep renewing it, and he keeps surprising. So, and he's getting very good care. And so if the time's appropriate for hospice involvement, to involve them sooner than later. A lot of people have a hard time taking that step, though. So, I wish we had better predictability. That's the bottom line. Yeah. Okay. Yeah.
So you mentioned pretty strongly no Haldol, but without explanation. What's up with that?
Yeah, good point. I should have explained it more. So Haldol, medicines like haloperidol, Haldol, Thorazine, Selazine, Mellaril, they're old anti-dopamine medications, and what can happen is a phenomenon known as neuroleptic sensitivity. One tablet of a low dose of Haldol can cause marked Parkinsonism, and it doesn't reverse, or it reverses partially over months. I've seen this happen many times. I actually will, with essentially all of my LBD patients, I will write that they're allergic to Haldol and those other, just so that they're never exposed to it. It's kind of a, maybe a fuzzy trick, but I've seen families where they tell the clinicians, please, no Haldol. They get hospitalized, and sure enough, they get Haldol. And then they get so rigid and can barely converse for weeks or months. So that's the neuroleptic sensitivity. It doesn't happen that often, as far as we know, but when it happens, it's severe and it's avoidable.
Actually, it's very severe. Is this on? Doesn't sound like it. Thank you.
Sure.
It's quite severe and very scary if you're the one called at 3 o'clock in the morning to go to the ER, but that's not my question. I have dealt with Parkinson's. I do support groups. I taught advanced nursing and so on and so forth. And I have had definitely five people with Lewy body disease. All but one had heart disease. My question is it somewhat like Parkinson's? We have 10 non-motor symptoms and 10 motor symptoms. Could cardiac problems be I'll call it a non-motor, but it's autonomic. Could it be a pre-symptom that one should start to look at and investigate?
Good question.
I'm not done.
Okay. It's a very good question. One of the earliest predictors, I didn't spend a lot of time on this, is the MIBG. So the MIBG is a nuclear medicine test that you take a picture of the heart, and it's always abnormal early in Lewy body disease, the same thing in Parkinson's disease. And in REM sleep behavior disorder, again, a real early manifestation of evolving Lewy body disease, many of them have a very abnormal MIBG test also. The reason we don't do it very often in the US, again, is cost. It's about $3,000, and usually insurance or Medicare won't pay for it. In Japan, they do it very routinely, so most of the data we have is from Japan and some from Korea. Very compelling data, though. So, yeah.
How early does it show up?
How early? The abnormal MIBG. If you look at the Japanese literature, it's hard to say. What do you mean by early?
Like, if you take
They, to my knowledge, they haven't done this routinely in a population to know what's normal, 20, 30, 40, 50. But in people with REM sleep behavior disorder, some of whom are in their 40s, it can be abnormal. And there are people that we're aware of that have had REM sleep behavior disorder for over 50 years. For example, their spouse was punched in the face as part of a dream on their wedding night. And 50 years later, then developed DLB or PD. So this suggests Lewy body disease is really slow in some people and a lot more rapid in others. So, so it's hard to answer your question. It's a good question, but yeah.
I wanted to mention we have 90,000 Vietnam vets with Parkinson's, and I worked in Washington to get them finally to recognize it, but that's just me. And I'm from Traverse City, Michigan. I have a yearly seminar. It is May 30th this year at the Haggerty Center. We have a lovely area in Traverse City, and we are the best winery place. I mean, you can spend days at the winery, and now we're picking up with breweries. If you'd ever consider coming to Traverse City, that's me, and that's how we're going to have it. But let me tell you, really and truly, it's been excellent. I'm very pleased with it. I'm very critical, and I thoroughly enjoyed it, and thank you. Good job. Well done, my friend.
Well, thank you very much. Critical view is far more better taken than from lousy physicians, that's for sure. So,
Think you can stick around for a few minutes?
oh, sure.
If we have any
sure,
more questions?
Sure, yeah. I really appreciate, I didn't realize it was going to go so long, so I really appreciate your attention. I'm happy to stick around for whenever. So, thank you again.
If everyone could, I do have a yellow piece of paper on at your seats. If you could take your evaluation, those, we really do actually read those and improve our presentations based on the feedback we get. And I just want to thank you all for being here today. I know that Tamara and Carl and everyone else we lost this past year are happy that we're together today. And thank you for coming so much. If anyone would like any more information on the LBD support groups or research, we'll all be outside at the tables there, so feel free to stop by. And thank you.